Hi, I'm Dr. Scott Weiss. Today we're going to talk about lumps and bumps around the knee. I'd like to thank Sonosite for giving me the opportunity to present some interesting cases to you. I'm going to have a focus essentially on Baker's cysts because they're so common, and we're going to discuss different kinds of cysts and also different findings you may see within the cysts, such as septations, loose bodies, and multilobular cysts. Also, I'm going to discuss a ruptured Baker's cyst and findings you can see in the gastrocnemius muscle with a rupture of a Baker's cyst. So Baker's cysts are very common. You see them often with osteoarthritis, you see them with meniscal tears. Even the pediatric population sometimes has them, even without any trauma. And very often in the pediatric population they will just go away by themselves, but it could take up to a year. In the adult population, I usually don't interfere or do anything to a Baker's cyst if it's not causing any symptoms. Unfortunately, even if you drain a Baker's cyst, it very often comes back. Baker's cysts have been described as distension of the bursa, basically between the medial gastrocnemius tendon and the semimembranosus tendon. Patients that are over 50 years old, 50% of those patients have communication with the knee joint. And when you diagnose a Baker's cyst, you want to be able to see a stalk that is basically between the medial gastrocnemius tendon and the semimembranosus tendon. Baker's cysts usually are located distal to the joint, right over the medial gastrocnemius muscle. If you start noticing a cyst more proximally, then you start thinking more of a ganglion type of cyst. If you see a cyst that's underneath the calf musculature and certainly if it looks irregular with different types of echogenicity within it, then you actually worry about a soft tissue tumor or sarcoma, and certainly that is something that needs to be worked up with MRI imaging. So here is a model of the lower extremity. We're looking essentially at the femur all the way down to the ankle. We can see the posterior aspect of the knee here, and we rotate anteriorly. You can see the articular surfaces. Most of our focus again is going to be the posterior aspect of the leg. And here you can see the posterior leg and the posterior aspect of the distal thigh. You can see the plantaris muscle and then very long tendon going distally. Also the popliteus muscle you can see just below the knee joint. And here's the deep muscle compartment going from lateral to medial. You can appreciate the flexor hallucis longus muscle, then the tibialis posterior muscle, and then the flexor digitorum longus muscle. The plantaris tendon actually is just superficial to the soleus muscle, which you do not see here. Here we are going to a more involved model with muscles of the hamstrings. You can see the short and long head of the biceps femoris muscle laterally, and then medially you can see the semimembranosus muscle / tendon with the semitendinosus muscle / tendon above that. Baker's cyst you can see above the medial gastrocnemius muscle, and within this Baker's cyst you can see some loose bodies and septi. Here on a sagittal type of perspective you can see how it just lies superficial to the medial gastrocnemius muscle, making it a relatively safe bursa to aspirate. And here we are, we're kind of looking at it from below, and here's our probe. Now when you do an ultrasound study of this, you want to make sure you cover both axial and sagittal views. When you do sagittal views, you want to make sure you cover both the medial and lateral aspect of the bursa, which you can see the probe moving on both sides of the bursa here. And here again is another sagittal view of this bursa, and again you can appreciate how there could be septi both distally and proximally, and loose bodies throughout the Baker's cyst as well. When you decide to aspirate and inject these, basically you have the probe in a sagittal perspective or long access to the Baker's cyst, and you can see how you may have to puncture and go through different septi in order to drain the entire Baker's cyst. Here's just a close-up view of how the needle may have to penetrate the septi in order to aspirate the entire cyst. You'll see in some cases that you may not even have to go through the septi in order to drain the cyst. That really depends if the septi is completely separating the Baker's cyst or not. And here we are going back where you can appreciate the C-shaped Baker's cyst with concavity going lateral. And you want to make sure that the Baker's cyst is essentially superficial to the medial gastrocnemius muscle. If you start seeing a cyst which is going into the muscle, below the muscle, then you actually start worrying about a neoplasm such as a sarcoma. If you see fluid tracking distal to the Baker's cyst into the medial gastrocnemius muscle, then a ruptured Baker's cyst is probably your diagnosis. Baker's cysts are usually caused by fluid that extravasates from the knee joint posteriorly through a weakening of the capsule. Occasionally you could just get local irritation of the semimembranosus medial gastrocnemius bursa. But again, often a Baker's cyst is caused by arthritis or perhaps meniscal pathology causing fluid which then extravasates posteriorly. In this case, you're going to see a Baker cyst that has a septum in it, in the distal third of it, and actually to drain this cyst, we didn't even need to breach that septum, we just needed to put the needle just proximal to it. Usually, however, in most cases, you need to breach the septum in order to get different compartments drained of the Baker cyst. This is a case of a 52-year-old female complaining of 5 months of pain in her right leg. Most of the pain seems to be posterior. MRI and ultrasound did reveal a Baker cyst with a septum in it. She also had a torn posterior horn medial meniscus / medial meniscal root tear, posterior horn. In physical exam, she was tender in the medial joint line, also, again, tenderness in the popliteal fossa. Here we are starting our diagnostic ultrasound with comparison view of her normal side on the right side. We're just going through a medial gastrocnemius muscle and soleus muscle underneath that. And here we are in a sagittal view, and we can see her Baker cyst with a septum in the distal half of the Baker cyst. Again, to diagnose a Baker cyst, you need to have it basically squeezed through between the semimembranosus tendon and the medial gastrocnemius tendon. Here's a good view of our semimembranosus tendon attaching on the posterior tibia, proximal medial aspect. And there's the MRI as well. Now we're switching to an axial view, and we get a really nice view of the septum. And it looks like it completely transects the Baker cyst in axial view. Here are some MRIs just to show you again the anatomy of Baker cysts and how we classify them. Here's a good breakdown of her musculature and axial view of her knee. Here we are just scrolling through and can see that Baker cyst start to form, and you see how it squeezes out between the semimembranosus tendon and the medial gastrocnemius tendon. Here we are just focusing again on those cysts, on that cyst with those two tendons. And here's just a scrolling through again of the axial view to see how that cyst forms. Here's a sagittal MRI, and just to look at it again, you can see the medial gastrocnemius tendon, and then as you go more medially, you will see the semimembranosus tendon start to come into play as well. And here's our semimembranosus tendon. And we're just scrolling through to get a better sense of how this cyst forms between the medial gastrocnemius muscle / tendon and the semimembranosus muscle / tendon.
That was not painful.
That's me just going in.
Okay, we're starting our procedure.
First.
So in this stage, in this part of the procedure, we really just went in the proximal, or actually the distal part of the cyst, and we didn't go through the septum. I was anticipating having to breach through that septum in order to get to the proximal part of the cyst. But as you can see, most of the cyst really was drained just by putting the needle just distal to the septum. So I didn't really need to break through that septum. So it's my conclusion that this was not a complete septum or complete division of the Baker cyst with that septum. I'm just going to inject it with a little bit of cortisone. Give it cortisone. Here we are, we're just injecting some cortisone. Sometimes when you break through plica or septum, it could cause more discomfort for the patient, so if you can avoid it, it's probably easier on the patient. And again, teaching point is that on this case, we did not have to go through the septum in order to essentially drain the whole cyst. In this next case, is somewhat an unusually high location for a Baker cyst. Once you get beyond or proximal to the knee joint, you're usually dealing with a ganglion around the semimembranosus tendon. But this case, I believe, is just a Baker cyst that is a little bit high up, has some loose bodies, and we're able to successfully drain it. 51-year-old female here for pain in the right knee for about a couple months, no injury. Pain posteriorly, she has a nice Baker's cyst. Here we're starting medially. We can see a loose body there in the Baker's cyst. Right side of the screen is proximal, left side is distal. And you can see that Baker's cyst goes right above the medial gastrocnemius tendon. Very medially. We can see the semimembranosus tendon coming down and inserting on the proximal tibia. And you could easily mistake the PCL for the semimembranosus tendon. And you can see that crisscross pattern between the semimembranosus tendon and the medial gastrocnemius tendon. We're going a little bit lateral, and we can see that cyst just kind of come into view there. Again, loose bodies proximally in the cyst and septation distally. Now we can see the medial gastrocnemius muscle and tendon going right underneath the cyst. Now we're going to take a little axial view. Right side of the screen is medial, left side is lateral. And we're starting basically above the cyst. Now we're going down. And we can see it come with those loose bodies. See the communication channel. You can see it right above the medial gastrocnemius muscle. Starting below now, and we're coming up. Here's a nice view of that channel as it comes up. Here's that septum coming across. Sometimes you get a better view of the septum in a different plane. Just keep going proximally. You can see those loose bodies form. So one thing you don't want to do, you can look at the cyst. If you think that little black circle next to it is part of the cyst, it's really anisotropy of the semimembranosus tendon. There's a really nice view of the septum going across the cyst. And we're going to start our aspiration. There's a nice reverberation artifact of the needle, and the cyst drained pretty easily. You can see how the tissue converges around the needle, and ultrasound can help you keep your needle within the actual cyst while that tissue converges around it. Now we're just putting the cortisone in. Here's a case of a ruptured Baker's cyst, and this case is a great example of how the ultrasound can give you important information right then and there in the office, and I was not nearly as worried about her DVT after doing her ultrasound. This is a 69-year-old female here complaining of pain in the right knee / calf going on for about 3 weeks. She had x-rays done at the ER which didn't show any acute pathology. However, there was no report of an ultrasound done in the ER. Here's a sagittal view of her right knee in the popliteal fossa as well as an axial view, and we can see a fairly sizable Baker's cyst. Here's an axial comparison view of her medial gastrocnemius muscle of her right compared to her left, and you can see that it's much darker on the right side, and that's consistent with fluid extravasation within the muscle, and that fluid came from a ruptured Baker's cyst. This basically made the likelihood of a DVT much less likely for her, and we treated her in the office by aspirating the Baker's cyst, and she did much better afterwards. Here again, here's our sagittal view. And we can again see some fluid extravasation within the medial gastrocnemius muscle. And here we are in the sagittal view of the Baker's cyst. We're going in with a needle now. and essentially draining the Baker cyst. We basically drain from the distal pole. And here's a post-aspiration MRI, and the Baker cyst came back, which unfortunately happens quite often, but you can see how some of that fluid basically extravasated distally from the Baker cyst. This is a case where ultrasound can really help you right then and there in the office to differentiate whether this is symptoms simply from a ruptured Baker cyst versus an actual DVT. Here's a case of a 56-year-old female complaining of about 3 months of pain in her left knee. She had pain with walking, she had no mechanical complaints. And ultrasound did reveal a ganglion just medial to the semimembranosus tendon. On physical exam, she was tender in the pes bursa region, also in the medial joint line, so I think there was some pain referred from this ganglion. It's important not to diagnose this as a Baker cyst, as it does not lie between the medial gastrocnemius tendon and the semimembranosus tendon. And you have to have a fairly keen eye in order to identify this. 56-year-old female here for pain in her left knee for about 3 months, no injury. Mostly on physical exam, she has pain in the pes bursa region, also some moderate tenderness in the medial joint line. She's complaining of pain and stiffness with walking and bending her knee. There's no locking. Just looked at her MRI, which basically shows arthritis under the kneecap. It does have what appears to be a ganglion cyst just medial to the semimembranosus tendon. So we're going to go ahead and just look at that. Are you real tender over here?
Yeah.
Is it you complain of pain here?
Yeah.
Or most of your pain seems to be up here?
Wow.
So this is anterior. The cyst, I believe, is right here, just medial to the semimembranosus tendon. Now, she's got a nice little crease here, which probably causes some anisotropy and artifact. So I'm going to try to be a little more generous on my gel. And you have the semimembranosus muscle on the bottom of the screen. And here we can appreciate the semimembranosus muscle transitioning to a fairly thick tendon right above the medial femoral condyle. And now I'm just going to go distal. Here is that ganglion, I believe. Here's the ganglion cyst, somewhat inconspicuous as it kind of blends in with the surrounding subcutaneous fat. A little bit tender in there, huh?
Mm.
We got our semimembranosus muscle on the right and the bottom. Let's just follow that tendon again. Let's try to keep our probe flush. And here you can see the medial gastrocnemius muscle, and here you see artifact caused by the crease within the popliteal fossa. You don't want to mistake that for a cyst. Here it is, they're inserting on the tibia. Probably the best shot we got so far. Got medial gastrocnemius muscle. Again, right side of the screen is proximal, and as we go medial, you see that semimembranosus tendon. Here again is that thick semimembranosus tendon just over the medial femoral condyle. Let's switch to an axial view. And here's an axial MRI. You can appreciate that ganglion just kind of wrapping around the semimembranosus tendon and then going medially. Also, you can appreciate that the semimembranosus tendon is a pretty thick, wide tendon, especially compared to the semitendinosus tendon. Right side of the screen is medial. Here we are, we're looking at the semimembranosus tendon, anisotropy of the tendon as we toggle the probe. Here again, we're right above the joint line. You see the semimembranosus tendon, and then you can see to the left the medial gastrocnemius tendon. You may mistake this for a cyst because of the anisotropy. I go a little bit lateral, you can see that medial gastrocnemius muscle. And this is the cyst now, just to the right of the semimembranosus tendon. See, I'm toggling the probe and it's just coming out of view. But it doesn't light up like a tendon with anisotropy. It's just going out of view because the probe is just angling away. Now, watch what happens when I go over the semimembranosus tendon and I toggle it. Semimembranosus tendon. Now you can see that tendon. So when you toggle the probe, the semimembranosus tendon either appears like a black circle or a white circle, whereas the ganglion will essentially just go out of view. This is a case of a 11-year-old boy who presented essentially with a lump behind his knee for about 6 months prior to seeing me. There was no injury, there was really no pain in his knee. Ultrasound did show a Baker cyst. We did an MRI because I was concerned for any kind of intra-articular pathology, and we did actually find a very subtle osteochondral defect at the posterior medial femoral condyle. After about 3 months of rest and avoiding any sports, the Baker cyst went away. So here's our 11-year-old boy complaining of about 6 months of a lump in the back of his left knee, and really no symptoms other than just this lump. Physical exam really didn't show much other than a large mass in the back of his knee. Here's our sagittal view, and we can see the Baker cyst. We can see the semimembranosus muscle transitioning into the tendon, and you can appreciate how thick his hyaline cartilage is over the medial femoral condyle. And this is typical in the pediatric population. You can also see the medial gastrocnemius muscle and tendon nicely here as well. Here's an axial view. Again, you can appreciate the Baker cyst, and does have a nice thick septum within it as well. And you can see that stalk of the Baker cyst that goes between the medial gastrocnemius tendon and the semimembranosus tendon. And here's that subtle osteochondral defect over the posterior medial femoral condyle, which I believe was the cause for this Baker cyst. This next case is of a lady with a ganglion cyst just posterior to the PCL. It's important not to mistake this for a Baker cyst. It does not lie between the tendons of the medial gastrocnemius muscle and the semimembranosus muscle. On exam, she did have some pain palpation in this region, and essentially just reassured her it's just a simple cyst. It's a 49-year-old female, pain in her left knee for about a year. She fell directly on it. She does get some locking and pain with walking. MRI did show a small tear of the medial meniscus and a free edge tear of the lateral meniscus. She has significant diffuse osteoarthritis, also a Baker cyst, and she does have a ganglion of the PCL as well. So here's sagittal view on the back of the knee. Right side of the screen is proximal, left side is distal. Here's our first clip. We can see a subtle ganglion cyst, just inferior and posterior to the PCL. It's right under the popliteal vasculature. Put some color on it just to make sure I'm not mistaking it for a vein or an artery. Here's that cyst, and we can see that there's no color flow in it, so that does confirm it's a cyst. You can see the PCL right underneath it. Kind of have to go deep with this ultrasound so the structures are not entirely clear. Now, this structure does not go between the tendons of the medial gastrocnemius muscle and the tendon of the semimembranosus muscle, so it does not qualify as a Baker cyst. Now we're going to switch to an axial view of it. Right side of the screen is medial, left side is lateral. I'm starting up basically just above the joint. We're going distally. Here we are again. Just below the popliteal vasculature, we can see that cyst come into play. I don't want to mistake that for a vessel. I'm going to put another color on this again. Certainly this is important to do. You want to make sure it's not a popliteal aneurysm you're dealing with. And we're just right in the view of that cyst. I'd like to thank you for your time that you spent watching these cases. I hope that I've demonstrated that ultrasound can change the way you manage patients and hopefully elevate the standard of care that you give patients. Again, I appreciate your time and attention, and I'm looking forward to sharing some more cases with you in the future.